Anyway, we are very, very fortunate today to have one of the leaders, a visionary leader in long-term care and rehab. She was the director of nurses for many years at a 100-bed plus facility and greatly improved outcomes for her patients and worked very strongly to improve life therein for the nurses, increasing job satisfaction while she was increasing outcomes. So I am honored and delighted to introduce you to Jacinta Vondell. Take it away.
Thank you so much for having me tonight to speak with you. Karen's already introduced me. I did put together a PowerPoint. Actually, I can't lie, my husband put it together for me with all the information. I threw it in, but I'm not going to just read through that because everybody has access to it. Yes. I can share it if we want as I'm talking, whatever's better for everyone. But really, it's all about having that conversation together just to get some information out there to everyone. So I'm going to kind of use it as my guide, but I'm not going to just read through everything. I might not hit every point that's on it because you'll have that as a resource, hopefully. And then at the end, I'll make sure that you have my contact information if you want to reach out to me. And once I'm done speaking, hopefully you'll have some questions that will maybe get us a little bit, let us dig a little bit deeper into maybe some real solutions to some situations that you've run into. So once again, I'm really happy to be here. My title for my speech tonight was A stands for advocacy, not adversarial. There's such a misconception as to what the RN advocate does. I think that's the huge stumbling block, is that people do not understand the service that you're providing and how very important that it is. We get stuck on ourselves so often with things that we don't give ourselves an opportunity to learn about what somebody else is doing, how it's really a benefit to us and not something that's negative. So there's not a lot of us here. Are you comfortable with me not having the PowerPoint up so you can see me, or what?
Everyone has, I sent out the PowerPoint, everyone has it. But let's ask the group. There will, as I mentioned,
I have it up, so I mean I can hit share. We can share it if that's a preference.
Well, I have a question for you.
Okay.
One of the things that we teach our nurses is that if at all possible, they should go introduce themselves to the directors of nursing of the hospitals where they will most likely what's going on? We're getting feedback.
I think somebody just joined the meeting.
Okay. Anyway, I recommend that they go meet with the director of nurses of the hospitals where they will be having clients, because that way they don't just show up and go, here I am, and nobody knows who they are or what the heck they're there for. And so would that also apply in the long-term care setting?
It would. Honestly, you do want to meet with the directors of nursing, really only to get your foot in the door to meet with the nurses. You want to get to the floor nurses. The floor nurses are the people who have the contact with the client. They're the ones that are going to be involved in their care planning, in making sure that all the information is properly obtained and that it's where it needs to be and that everyone knows what they need to know. So your director of nursing is the head person in the whole building. It's sometimes really hard to get a meeting with that person. What's not hard to do, and towards the end of what I had in here was, how do you really make that happen? Call and say, can I come in and bring lunch and meet with your nurses to talk about patient advocacy, about an RN patient advocate and what we do. If you bring them lunch, I'm not going to lie to you, you're still only going to have their attention for probably 15 or 20 minutes. So you really got to stick to the points that you want to really drive home. They need to know what you guys do, why you do it, but what you do, so that they feel like when you're coming into that nursing home as an advocate for that resident, that you are not trying to be there to point fingers at them, that you are trying to make sure that they have the best positive outcome that they can. So actually, I have there. It's a lot of it. a lot of it's about perception. We have very often don't have an accurate picture of what you do. And I don't think a lot of times that you have an accurate picture of what the nurses are doing. And so when you guys come together, it becomes very tense. And in here, I talk about being offensive versus defensive. We start saying, you put your wall up. You're just like, I don't want to deal with this person because they're just here to tell me things that I already know, or just they're here to pick at anything I might have missed. And that's completely wrong. And I really know that that's wrong, that that's not what's really happening, that that's not the intention, but that is what a lot of times happens. And it's because they don't know what you do. So I'm gonna kind of, I know you asked me a question, Karen. I'm gonna ask if I can kind of just quickly go through what I have, which I think will touch on a few points, and then I can kind of elaborate, and it won't seem as, I won't feel as scatterbrained as I'm probably sounding right now. So
No, you're not. I just want us all to throw questions at you because
absolutely.
the depth of your experience is excellent.
Yes, and I can answer, and I will answer everybody's questions.
Hey,
I'm
hold
thrilled
on.
to do that.
There's a lot of noise. Somebody needs to mute. Thank you. Okay, sorry, go ahead.
No, that's fine. So anyway, right off of your website, I stole some stuff from your site, Karen. It just talks about the opportunities that nurses have to be full partners in the healthcare professional team. That's really true. But what it says is we have an opportunity. I think a lot of times we miss the opportunity to be partners. And that means that entails us actually working together. We're never going to be successful, us as nurses in the long-term care community and as advocates, if we don't build that true relationship that we are always going to put our resident first, put our egos aside, and start working together.
Well, it might be helpful for us. And anybody else, feel free, please, to just ask questions. I know next to nothing about working in long-term care. What is a nurse's life like? The level of responsibility. What is that like for the nurses? If we could better understand that, perhaps we wouldn't walk in with such ignorance.
Yes. So maybe I can talk about what the admission process is like for when a resident comes in and what the nurse is looking at and doing. So when we have a new person coming to the facility, they are coming either from home or from another nursing home or from an acute care hospital stay. We would reach out to wherever they're coming from and ask them to provide us with information, which I'm sure is a lot of what you're doing, is you're gathering a lot of information. And we hope that all that information is actually going to get to us before the resident arrives. So we have a chance to review it. We have a chance to make sure that all of it's there. And so they're working, trying to do that. At the same time they're doing that, they still have all their other responsibilities of their day. So this is just kind of another thing put upon them. It's not like the nursing homes have set aside a single nurse who her only job is to do admissions. That's just one more thing that they have to do when admission comes in. So currently I'm working in Long Island and I'm helping a facility transition a new director of nursing, and I'm trying to help them put some systems in place so their nurses can work more smoothly. I was there the other day, they had 5 admissions in one afternoon.
Well, if your intake is anything like ours, that sounds like a near impossible task.
Well, and it is. So what happens? You don't get everything that you need. It doesn't all get done, and things get mistaken, things get lost, things get not done until the next day when you go in and clean it all up. That's not optimal. So what we tried to do, because we didn't know until very last minute that they were getting 5 admissions and there were only 2 people there available to do admissions. So what we tried to do was pull people who, it might not be what they do all the time, but we pulled other nurses to come in and help with those admissions to kind of provide another layer of support. So we were I was teaching them to work together instead of, because the first response I got was, well, I'm the ADON, I don't do admissions. That was the first thing the person said. I said, okay. Do you have an RN at the end of your name? Yes, then you can do an admission. So I said, let me show you how to do that. And I quickly went on and I pulled off an RN checklist I have for admissions. And I said, this is what you're going to use as your guide. You're going to take care of one of these. I said, now, if you start feeling like you don't know what you're doing, you're going to call and ask somebody else to help. But we divided it up so that we could work together. But in a normal facility, if I wasn't there that day, those 2 nurses would have done all 5 of those admissions. And they would have only been done minimally. So I'm trying to build them a system so that's not the case. So go ahead.
Talking about, everybody pitching in to get the job done. I don't know what the federal guidelines are for staffing. I don't know how many RNs versus LPNs versus home health or,
So in long-term care, at least in New York State, I know in California, it is different. It is state by state what those regulations are. New York State does not have a minimum staffing regulation. It's a generalized statement in their regulation that says you have to have enough people to provide the care. They don't say what that is. There's no definition. Now they define everything else. New York State's regulations are this thick, but that is their statement on staffing. So there are a lot right now. We're going through a time where, of course, people are trying to get their census up because with COVID, there was a lot of people who passed away, and many facilities have had to reduce even the parts of their building that they're using. They've shut right down because their resident census is so low. But so that's why they're having things where they're getting 5 admissions in a day, is because they're trying to fill up beds and hopefully be able to sustain themselves. But beyond that, that's a whole nother that's a whole nother thing that's happening. But so when the admission comes in, a nurse is supposed to greet them, look at all their paperwork. Hopefully they got there before then, they had a chance to review through it, but they sit down, have a conversation with the resident. They do their physical assessment. They review the meds that they have there, and then they go back and they review it with the doctor. That medication reconciliation is so important. And so often I find that's one of the main places where mistakes happen, because the resident is telling the nurse about stuff that is not necessarily on the hospital discharge paperwork. Now she has to go by what's on that discharge paperwork. So then she's got to call and find out, is there anything else, and call the doctor. The new client is saying, I take these other medications at home. So that's something that I think that, if I'm right, that's one of the things that you guys are really focus on to make sure that we have a proper list, that list is able to be reviewed in its totality.
I know I explained our MedRec process, which is pretty cool. Then that might be one of the very valuable things that we can bring to your team.
It's hugely valuable. The biggest part you can bring to the team is, once you meet with the facility, go in and meet with those nurses, is to become part of, when you bring in a client, become part of their interdisciplinary team, their IDT. That's huge, because what that is, that's the whole team of people within the nursing home that is providing the care for that resident. You can be part of that. You do not have to, all you need to be part of that is permission from their client that you work for, is that you would like them to, they would like you to be part of that team. When you have that, we literally, a lot of times right now we're doing them via Zoom. Sometimes we're doing them in a room together. A lot of times we're doing the room and maybe the doctor's on the computer screen instead of being in the room with us, but we're talking about everything at one time. So we can discuss everything that's going on.
Well, I think it might be a good idea, and please don't let me be the only one asking questions here. I think that it would be helpful if you were to understand what our view of coming into a facility. We are not there to point fingers, not our job. You have X number, I don't know how big your teams are, but you have X number of patients, and we have one. And that means we're going to be meeting with that family a lot. We are going to get a lot of in-depth information that your staff does not have time to get. And we are nurses just like everybody else, and we are going to share all that information so that you have a broader understanding than your staff has time to get. We will never go over your head. We do not call the doctor. You know, if we think that a doc needs to be called, then we'll talk to the nurses, and they would be the ones. This is your house. This is your, you know, facility.
Karen, can I jump in here?
Yeah.
Hi, Nan.
Jacinta, hi. Since I'm in Florida, I deal with a lot of these, and I have to tell you, they'll know my name. I call, they know, because of COVID, you can't just go in and have all of this stuff. They've been pretty strict because they keep shutting it down. And I've got people in multiple different types of long-term care facilities, from assisted living to long-term care to skilled nursing, everything in between, memory care. But they know who I am, because right away, when I know they're going to be transferred there, I don't care if they're in a hospital, I don't care where they are coming from. I send them my medical timeline, which is chronologically ordered for each of my clients. I try to keep it to 3 to 5 pages. Their medication list, which is what they had before they went in the hospital, clearly stated when they started. Their contact, my full contact list of all of their doctors. And I write next to each of them who they are. They're all listed, whether PCP, neuro, whatever. And the phone numbers for them and the name of their assistant. And then I fax it to, I call and ask for the fax number. I fax it to them, and then I call them. Usually when they're going to be transferred into a long-term care facility, I have to talk to the admissions person first, who is usually not a nurse. That's the first person I talk to. I tell them what I'm going to send them. Of course, my HIPAA form goes with that, and the power of attorney and the health surrogate forms. All of those are faxed to them. And I can tell you that when I call them back and go, did you receive my fax? Yes, the doctor wants to speak with you. Do you have time? Of course I have time.
That's great.
And that
Well,
doesn't matter
you
whether it's an
have- you
emergency
have-
room for a hospital or where it is. I follow that rule. And every one of
So
the
that is-
long-term care
that-
facilities,
Leanne, that is-
that's what
that
I
is-
do.
That's wonderful, but that is not the experience that I've had here in New York with I know I've only dealt with a few people. That is certainly not what happens. It's usually very adversarial. It's usually very much, instead of that introduction that you did, you're providing information, you're sending it ahead of time, you're proactive. That's great. And you figure at that point, the doctor's asking to talk to you. Let me glean from this woman the information that she has. And that's in the presentation, in the fact that you have a system in place that I am here to help and support this resident or this client to meet their needs and their goals. That's what it's all about.
Can you
We
give
just need to
us,
get everybody else on that page.
could you give us an idea of like some stories or examples of scenarios gone bad?
Most of the time, it's just information not being people assuming that information got to that person or that they have that information. And what it's better to do, I just recently had a family who had an advocate. They didn't let us know the person was their advocate. We didn't know she had permission to speak on behalf of this person or to communicate things, or that they just weren't upfront about it. Instead they were just like, oh, she's just a friend. Okay, well, I can't just talk to a friend. Yeah, I mean, I'm the director of nursing service. I mean, everybody's pretty nice to me because in general, I'm nice to everybody.
Well,
But the nurses on the floor are like, I can't talk to her. And I'm like, so then I got to the bottom of, she's their advocate. She has full ability. She signed all the paperwork. She can do all, but they didn't know that.
you gotta understand something. I'm gonna jump in here because this is very, very important to hear this, because especially given the name of this presentation, advocacy versus adversarial, right?
Yes.
So, a lot of the advocates are taught that, and it has been the case for a while. I think that we've made incredible progress over the last handful of years, but there always has been pushback from the institutional side in terms of getting somebody else on on board. You know, some people think that you're looking over their shoulder, and it
Mhm.
needs to be explained that you are there for the right reasons. But for a long time, a lot of advocates, when they would use the word advocate, that would light up a light bulb in the mind of the facility saying adversarial. So
Yeah.
the trend for some of the advocates is to go in as a friend to avoid the adversarial perception of an advocate.
Absolutely,
So-
absolutely. Because the first thing I thought about when Karen and I talked and I was going to put something together, when I was talking about advocacy, next word out of my mouth was adversarial. And I know that's not the case. It's certainly not anytime I've ever spoken to Karen. But it was what came to my mind is what the perception is. And so often it's just and Karen, when I talked, how do we change that perception?
I have a question. I'm sorry,
Yes.
Oh, that's okay. Go ahead.
Nan. How often do you encounter independent advocates? What
I
percent?
have not had a lot. I've probably in the last 3 years, and also you figure the last 20 some months or whatever, it's been COVID. So, you know, everything's been very different, but maybe 3. It's not huge. It's not, I'm in central New York most of the time. I just recently have launched a new company where now I'm traveling all around. So I think I'm going to get a lot more experience in different areas. So I think it'll be different. I'm in central New York. It's not a highly populated area, you know. Right now I'm in Long Island. I'm expecting that I'm probably going to meet a few. You know,
Well,
it's
it-
a very
Jacinta-
populated area. There's 5 nursing homes within like 3 blocks.
Jacinta,
So,
I
yes.
did change from being called an RN patient advocate. It's on my website, but I call myself a healthcare advisor. And I did that because when I say I'm an RN patient advocate, the first thing out of someone's mouth is, "Are you a lawyer?"
Mhm.
No, that's what the RN stands for. I'm a nurse. Oh, okay. And they'll
Yes.
talk to me. But the fact that I use the word advocate, they think, you guys are thinking adversary. They're thinking lawyer.
Yeah,
Yeah.
they're
So-
thinking that you're gonna sue us.
Yeah.
You're trying
Yes,
to find out what
absolutely.
you can sue
You're-
us over.
you're
So
here-
I call myself a healthcare advisor.
Yes.
And they're like, "Oh, what's that?" And I go, "Well, you know, I also work," and it says /RN patient advocate. And they go, "What is that?" So I have my spiel down to like 2 minutes or less. And they go,
Yes.
"Oh, that's cool. Okay." And then they want to talk to me.
Yes, absolutely. So my new title is Healthcare Resource Specialist. It's same thing. I'm trying to come up with something that allows me to get in the door and talk to people and then not be worried that I am trying to point fingers or pick out what you did wrong, because that's truly the thought process of the long-term care nurses. One more person in here to see, what did I miss? What am I not doing correctly? Not that you're there to work with them to get the best outcome for the resident. And that's what we're all about. Yes, Karen.
This is fascinating. And it occurs to me that what might possibly be helpful to alleviate any problems interpersonally is if we could, as RNPAs and you with your amazing background, put together a protocol for when we go into a facility. Here's our protocol, and that would be based upon your needs and what we can provide. And that could then be shared everywhere. Obviously, this is something that'll need to be thought about a great deal. What do you think about that?
I think we could definitely build something to give people better ideas, especially working with the experience like Nancy. She's already come up with, I call it your elevator pitch, right? Once somebody asks you the question, she's got a set thing of, this is what I'm going to share with them because it's going to give them what they need to know. And I'm now going to be able to do what I do, once we get past that wall, get past the blocks that they put up for us.
Well, that's what got me thinking. I'm listening because Nan, I didn't know that that's all what you did when going into a skilled facility. I think that could be built upon, and that's something that we could share everywhere to begin to break down the perception that we are adversarial. I think it's beautiful what you've done, and I'd love to see more of that. And we could certainly, Jacinta, use your input so that this is a really solid package that the facility would have ahead of our even getting there.
But the
Absolutely.
thing is, Karen, I do this not just for the long-term care. I do it for emergency rooms everywhere. And they understand, they look at it and go, oh, you're giving us credit for understanding and knowing this. And I go, of course I am. You're a nurse like me. And
Right.
I always thank them. I always
You-
thank them for their time. And I always
Yeah.
say, I'm a nurse. Tell me when the best time is to call so that you have time to talk with me. I know how busy you are.
Right. Just the
Absolutely.
word advisor means you're giving them something instead of pointing fingers.
Mhm.
I really like it.
So I had a situation happen the other day to me. I call it my black coat story. I went into this new facility down in Long Island, and I had a beautiful new lab jacket on. It was black, and I had scrubs on underneath. No one knew who I was. I came right into the building because obviously the owners knew who I was and the administrator did, but no one else did. And I consciously wanted to make sure people knew who I was. So I went to every person I saw, I tried to stop and introduce myself, tell them who I was, so they didn't think I was the Department of Health, the ombudsman, who else? Any other government agency that's just walking in the door on us at this point, and they just walk in and say, oh, let's do a new audit. Let's see what we can catch these people out today. But anyway, so I'm walking around trying to do that. And I'm introducing myself. I'm the new resource consultant here. I'm here to help and support you as a team, type of thing. And they are, okay, some of them are a little shy. They're like, I don't know if we trust this person because I'm brand new. So I've been there about 2 weeks. I find out the other day, there's a few people that are really upset with me in the building because they still have no idea why I'm there. Now I'm thinking, I've really put forth a conscious effort to make sure they know why I'm here, that I'm here to support their clinical team. I'm here to help put systems in place so things will run smoother, so that we can work together. Get out of your office, let's work together. Don't just do this. Like I shared in the beginning, the ADON who said, I don't do admissions. Yes, you do. We were all going to work together, and we came up with a plan and made it work. And we had successful admissions that didn't have to turn around and go back to the hospital because they weren't getting the care that they needed. But in doing all that, so I met with the person and I said, why are you so upset with me? And he goes, you came in and he said, you didn't introduce yourself to me. Now I know that I had, but I said, I'm so sorry. I really thought that I tried to do that. And he says, for the first few days you were here, he said, I just assumed you were the Department of Health. And he said, so I was just, terrified. And you know what I mean? So sometimes we can think that we have done everything we possibly can to introduce ourselves, to give the information. And like with Nan was saying, she has a system that she uses, which is really great. And you hope that that information then gets to the next person. So they actually get that wonderful information that Nan brought forth, that it's gotten to the person that's supposed to. And I'm sure you follow up, Nan. I know you must, because I can see that you would not let that
I have
go.
to call every single day. And I had people that have been emergency room to the ICU. Ooh, they lost all that information. I fax it again. ICU to the floor. Ooh, they lost that information. I fax it again. I faxed 5 times to one hospital.
Mhm.
So yes, I know you do have to follow up, and every single day it's different because it's a different nurse.
Yes.
Yeah.
Now, one of the nice things is I know that a lot of the long-term care facilities are really trying to implement having a nurse be in their admissions department, that it not just be a unit secretary or a secretarial position, but that person would minimally have an LPN. So they would have some sense of understanding of what they're looking at. And one of the other negatives though, that I hate to be negative, but one of the negatives in long-term care is some of the larger facilities that own multiple facilities have gone to what we call a center doing all their admissions. So the people in the building have no idea who's showing up. They have no input on whether or not they whether they have the ability to provide the good care for that resident.
What
Is
bright
everything in
bulb
place?
figured that out? Good grief.
Yeah, so it's a way for them to save money. They have one building that's filling beds for all the facilities. And a lot of times when that happens, there's a communication breakdown. So a lot of times things will get lost. Things aren't direct because it's not dealt with right in the building. It might be they're in New York City and they're putting admissions in central New York. And, you know, there's a lot of problems with that. Usually what used to happen is the director of nursing was directly involved in the admissions process. She reviewed every admission before it came. She was part of making the decision that that person should come into their facility because their care could be provided well. It's a dilemma now because that director of nursing has been taken out of that role. She has nothing to say about it. So now she has to play, now instead of being proactive, which is what she used to be, she's now trying to just play catch up and make sure that she can get everything in place as quickly as possible so there's no delay in care. And that has really, it's a new thing that they're dealing with. It was one of the things that got me to the point where I said, I'm not going to sit in that chair without being able to be involved in that admission process to make sure that everything is in place. I was extremely detail oriented when it came to my admissions. Everything was in that room before that person even arrived, because I wanted to make sure it was done that way. And if it was something new that nurses on that floor were not familiar with, we were going to go in and in-service them to make sure they knew how to use it. I had a family member come in and their family was being sent to the facility and the person was had a Clorox catheter. Now, there was only one nurse in that whole building that had ever used one. So we needed to quickly make sure we in-serviced those nurses so that everyone knew exactly how to manage that. When you're not involved in that admissions process, you might not realize that until they're already there. Now we're playing catch up. We've got to make sure people know how to do their job. And nurses are amazing people. They're extremely flexible, but you know, if you don't use your skills, you lose them. There has to be, you know, you have to be able to say, let's really quickly review this. Make sure you know how to do it. I'm going to show you so you really get it. And I tell them, don't feel stupid. I just watched a YouTube video. I always play to myself. You know, we always, if you haven't done it in a while, I always tell people when I'm in a building now, if you need somebody to go draw blood, please ask somebody else. Can I do it? Yes. Am I good at it? No. So let's go with somebody who's a little bit better about that in the building. Let me do the things I do really well, you know? So did you have something you wanted to add, Karen?
Well, it's just that not always, but frequently, we are part of getting the resident into the door. I mean, you know, they're being discharged from the hospital and we are very involved in getting all the information that we need, you know, as they go into rehab or SNF. So it would seem to me that it would be helpful to develop a problem list before we do the protocol, a problem list from both sides, but especially from the long-term care side, and see how together we might resolve the situation in a universal way so that this would apply across the United States.
I want in.
What?
I want in. I mean, it's part of the mission. I mean, I am, you know, I'm a firm believer that, you know, there has to come a time, and it has to come very soon, when, you know, advocates are not going to be the ones that are walking into, you know, subacute facilities, for example, and having to explain what they do. I want to get to the point where there are people like Jacinta who are maybe identifying people. Actually, they should be on the transferring outside, but there should be people in place that can identify somebody that's just going to need that extra help, that extra support, and feel comfortable asking the question, hey, do you have a patient advocate? Which I was going to ask the question, which is an ultimate goal of mine from the intake standpoint. You know, you ask about end of life, you ask about insurance, you ask about powers of attorney and next of kin and who's on the visiting list and everything. But I want there to come a time when there is also that question asked, do you have a patient advocate? or whatever it is that we decide eventually that we're going to call ourselves. Okay. But somebody to assist you who's a non-family member. And I just think that that would go a long way toward, like you said, the in-services and stuff. You can identify staff that can ask the question or whatever, get it in their head that there might be somewhere out there in the right case, somebody that could relieve the load, reduce the readmission, improve the care, improve the communication. And, you know, the more we can get that sort of, you know, cross referral instead of us barging in the facilities and pissing everybody off, we got to be able to identify. I didn't mean it that in a horrible way. Not
You're
you.
not a barger, you're not a barger.
Okay. So, you know, I'm just saying.
Bradley, I have doctors who send me patients. Call Nan, she's a patient advocate. This is what you need. And I always tell them, and you tell them my fee, right? And they go, yes, we do. And we tell them that you're worth it. Okay, I
got it.
Because I charge
That is
200 an
beautiful.
hour.
That is so beautiful. I get it. That's you. But obviously there are people that do not have that tact and that ability and that level of experience as an IRNPA. I mean, we got advocates all over the place right now that should be reaching out to IRNPAs, because I don't know if I've said it. I've said it many times. I don't know if everybody here has heard it. I believe y'all are the pinnacle, the cream of the crop, the top dogs when it comes to independent patient advocacy. I am a firm believer. And if I see those letters after somebody's name, I know that they are a total pro. But not everybody has access to one, and everybody needs to be able to reach out to people like you and make sure that we're, you know, so God bless. You know, that you could pull that off, and that, you know, you have that ability to smile and be firm and let people know that you're on there. You know, it's not adversarial. Some people.
Well, I'm well aware that not every director of nursing is a Jacinta. Jacinta is a real leader, envisioning what can be, not just what is, but what can be. And I think that perhaps, you know, whenever that there would be 5 or 6 of us, and we'll get together and begin to work on the solutions of problems that are identified, and a protocol that could be spread everywhere. How do you think that this would be received in the long-term care world, Jacinta?
I think what we have to do is, it's all about education. It's about getting the information into their hands in a way they can understand it. And the way that I would do it, because it's how I do most things when I want to really get a point across in a facility and I want to do a training and I want people to actually attend, is I do it over lunch. I bring food and I get their attention while they're having their lunch. And normally, even though they dock us for an hour every day for lunch, no one ever gets that. We're lucky if we get 15 minutes. So you'll get them for 15 minutes while they're eating. They will listen to you and they'll be thankful and they'll remember you because you brought them food. I know that sounds crazy, but it's the truth. They will remember you because you brought food, and they will listen to you. And don't just do it once, maybe do it a couple of times a year, because there's turnover in buildings. And then as you're coming in and you're having those building that relationship with the nurses, and you're coming in with clients, they're going to now see you as truly part of their team, because they know who you are. You're no longer a stranger. They know now that you were there to support the resident, that you're not there to point fingers, that you're there to really provide a service so that our end outcomes are what they're supposed to be. And that is, what does the resident want? What are their wishes? What are their goals? What are their dreams? That we can actually attain those things. One of the things that I really have been focusing on in every building I've been going to is even their perception of the ombudsman. The ombudsman is an advocate, is a patient advocate that is assigned. It's free. I believe that they believe it's a federal program. I'm sure that it is.
So that's from the Council on Aging, which is in every single county.
Yes.
It's federally mandated.
So, but this is the whole thing. It has always been, since I've been in long-term care, that the ombudsman is not your friend. No, they're not my friend, but they're there for the same reason that I am. And that's what the perception I'm trying to change in the long-term care community, is for them to understand that they're there because the resident needs somebody to speak to them because they feel for some reason that they can't speak to us directly about a situation, or they've tried and we have not listened to them. So, you know what I mean? So when they come in, I just had two ombudsmen come in and I greeted them. I thanked them for being there and they laughed at me. They literally laughed at me and they said, seriously, Jacinta, you're glad to see us? Yes, because it means something needs to be done. Either we're not aware of it or we didn't do a good enough job, but that's okay. What do we need to deal with? Let's talk about the resident. Let's talk about their needs. Let's talk about their goals and figure out how we can fix this.
I
Because
think
if we're
we need
truly
to-
here for the resident, which we all are, if we always remember it is not about us, it's all about them, that's the whole message. It is not about us. It's about them. And that's why all of us do what we do. It's certainly why I do what I do. I did not become a nurse until I was in my 40s. And I did it because I wanted to be part of changing what's going on in long-term care.
Jacinta,
Yes,
I've got a question for you. This has popped up a couple times for me. When the family wants something for the resident, and the resident doesn't always want what the family wants, we're there to help the resident. And I will tell you, in every one of those situations, they're very high maintenance people. That's the only term you can use for them. And
Sure.
the long-term care and the rehab facilities have said, thank God you're here, because we can't deal with them. And I'm like, yeah, it's all, let me tell you, it's really hard. I
And
don't
it's
love it.
difficult, like you said, yeah, because
So-
you have one person that you're focusing on, they're dealing with 30 or 40.
Right.
Yeah,
And
on
it's
their
the
unit.
family that's the problem. It's
Yes,
the children that are the problem. It's not
Yes.
the resident per se. Some of my residents have really bad dementia, but and they recognize it's not not exactly what the resident wants,
Yes.
but the family is controlling. So how do you deal with that? I try to help them, but we all are like banging our heads against a wall
Yeah.
on that one, but
Well,
yeah.
we always, obviously, we don't want to isolate the family out because that's only going to really make it more difficult.
Mm-hmm.
And constantly trying to talk to them about our common goal. Our common goal is what is best for the resident? What were their goals? Maybe before they had such severe dementia, what were their goals then? Because they knew what they wanted. Now they don't have the ability to decide and you're deciding for them. And I always go back to honor them, honor their life, and honor their death. Allow it to be what they had chosen for it to be. And it's a constant conversation. Sometimes we win the battle. A lot of times we don't. I just had a family who refused to honor their mom's DNR. She didn't really want that. Now, this poor woman is 99 years old.
Oh, my God.
She could have had her peaceful, natural death. Family said no. So she's suffering. They put in a feeding tube. They did a whole bunch of things. But you
How
know what I
many
mean?
ribs
That-
did they crack?
That was
Bringing her
not
back.
her mother's wish,
Whew.
but they, but there you have, and then you have to start, sometimes you got to stand in their shoes. They're not ready to let go because, right, you know what it is? It's all about them. It's not all about the resident. It's all about them because that's got nothing to do with the patient. I was talking today with someone in regards to them, was talking about their mom passing away. And she said, I kind of always get on myself. I'm upset about I did this. And she goes, then somebody finally said to me, it's just not about you. It was about your mother. And you beating yourself up about it still's making it about you. Still not about you. It's about your mother. Well, it was her wishes. You allowed her to have her death the way she chose to have it. Whether you agreed with it or disagreed with it, it's her. It's all about the client. And I always, when I'm talking to families, I always bring it back to, it's just about this person. Let's talk about what their life was like, what it was, what they wanted it to be, what their wishes were before they came here. Let's honor that. Let's honor what they wanted. And I can usually get there only because I believe it in my core. Some of my other nurses either don't have the patience to do it or they get frustrated. And so they can't. So I try and get people to toss it off to somebody who can deal with the situation. I used to spend a lot of time with talking to the families And
Well, this is
let me, and I would tell them, let me come to the care plan. I'm, as a director of nursing, I'm not always in a care plan meeting because when the facility I'm in now has 250 some residents, there's no way I could be in every care plan meeting. But if there's an important one coming up where you have an issue with a family that, you know, the nurses have hit that wall, bring in some fresh people to try and talk to them a little more and share some stories. I have such family experience, such personal experience that I can share with them. And a lot of times I end up crying with them because they understand, I really do understand where they're coming from.
This is a place where I think an RMPA can be extremely valuable. If there's a situation like that, pulling us in as co-problem solver, because we have one patient, you know, and we can work with the family more closely, simply because we have one. So I very much appreciate how you are trying to manage it. I also know that that's not typical in the facilities that I've been in. And I think this would be part of the protocol, and here's how you can really use one of us well. And you don't have to pay us because the client is paying us.
Well, everybody loves that, right? They love that part. They don't have to pay you. But I know my mission is to educate the nurses in the facilities also. I mean, I'm so big on education. So often why we fall short is really lack of knowledge. It's because we don't understand something. And either we're afraid to ask questions for some reason, whether we think we're going to look stupid, but really, if we talk to each other, if we can learn from each other and we know what people are doing, we can all grow. And in the end, we have a better positive outcome, and it still remains, it's all about them, not about us. And that's really everything that I can pour into anything. If it all remains the end, is that it's all about them, getting them everything that they need, and allowing them to have the life that they are choosing to have.
Well, here's a question for the RNPAs who are on the call, and there are quite a few of us on this call. What are your questions? What has been your experience working with long-term care rehab? Let's hear from you now.
Well, I work with them a lot, and they're it's been very difficult in Florida, I think all over the United States, but the shortage of not just nurses, but aides has been really, really difficult for everybody. And I will tell you that I had
staffing is the #1 issue in every single building throughout America right now.
It's horrible.
I know, I'm sure some people will not agree with me, but we had to let go of any staff member who was not willing to become vaccinated, period.
Well, I'll tell you, I had
and it didn't matter why.
The family hired somebody that was not vaccinated, gave it to, my client was vaccinated. That wasn't the issue. But because the aide that the lady needed at least 8 hours a day, she couldn't come in. We had a hard time getting somebody else because my client tested positive, even though she was asymptomatic. Getting an aide to come in and take care of a COVID positive patient in an assisted living went from $20 an hour to $40 to $45 an hour for the family.
Yes.
So the only way, and she fell twice. So I said, you know what? I called her doctor and the head of the nurse at the assisted living and said, you're going to send her to the hospital. She's going to be admitted. They're going to evaluate her properly because the emergency room you sent her to did not. And then I want her admitted to rehab. And then I'll find a skilled nursing facility for her. And that's exactly what we had to do. And that took 3 days in the hospital, 10 days in one rehab. Then we moved her to another rehab that was going to be at the skilled nursing facility. 4 weeks for this poor lady.
Okay.
And so she had dementia. She was very confused, had head injury, and none of this helped her. It took at least 8 weeks before she was able to even speak again.
Yes.
It's ridiculous.
Yes.
Julie Caruccio, you've been out there for a while, and I know that you're familiar with the long-term care world. What has been your experience? What are your questions? What are your thoughts?
Sorry, we're eating dinner.
Oh.
I've got like a mouthful.
I'm sorry. I'm sorry. Yeah, 4 time zones. It's always very interesting. I'm very appreciative that you even showed up in the middle of dinner.
No, I was glad that I was able to. I'm sorry. Yes, I do elder care. I would say the bulk of what I'm dealing with mostly is, or the bulk of my care and advocacy lately has been moving people into facilities, just that transitioning phase. That seems to be where I've landed lately. So I really have had very good experiences. I think up here in New Hampshire, not a lot of people, again, Karen, you know this, not a lot of people know what advocates are, what we do. So I spend a lot of time educating people, talking to them about the importance of it. But what I have found is that people are really appreciative. When I talk to doctors, they are so appreciative that I have information. I feel like because of COVID, there are a lot of doctors who have left the field, nurse practitioners. We are really struggling finding good doctors. So if I come with information, they are so appreciative. And so I haven't had a lot of negative experiences, I have to be honest.
Good.
I've been very welcomed in the assisted living, long-term care facilities. I still work in one that it's a CCRC. I still work there part-time just to really keep my skills up and my knowledge of how the facilities work. You know, it's so I get a little taste of everything, you know, the long-term care, hospice, assisted living, rehab, and then independent. So I do, you know, I'm kind of in the, you know, ring with all of it right now. But yeah, I've had good experiences, not a lot of negative reactions.
That's great. The first 48 hours too after admission is so crucial. So many things. That's when we're checking to make sure that all these things are in place. But there's a change from what Nan was sharing when this woman had to go into these facilities. Every transition is difficult. Every time that she had to be moved, there's all different things that you might have to deal with that are not even her norm. It's because of these transitions. So somebody that has familiarity with her, that knows what her baseline truly is a tremendous resource. And I do think that if people understand what your role is, that they will be very accepting of it, because you're bringing in that whole extra layer. It's kind of when hospice is coming in, and very often in the long-term care environment, they don't want hospice in their building. I said, why would you not want them in your building? It's another layer of support and care that we can have. But it's because they didn't understand what they were really doing. And they're like, well, we do that. I said, but we don't. They are going to take care of one person. We're taking care of everybody. It's another layer of support for that client in this situation that is going to benefit them. It's going to benefit their family. There's this whole process, but they had such a lack of knowledge. So one of those things, bring it in. Let's start in servicing and getting people on board to understand what it is. We can, a lot of facilities, once they get to know you, you could become part of orientation. You could become where you come in and you meet with new hires and take 15 minutes out of you to be able to explain, this is what we do. This is why we're here. So when we come in, this is what we're doing. And I will tell you, most people are more than welcome to include people in those processes, because it makes them a much better facility, which is going to mean more people are going to want to come there because they're going to have better outcomes. If we have better outcomes, people are going to want to come. And that's what the owners certainly want, right? And it all comes down to, once again, then we're going to be providing better quality of care. And
Well, I think you are inspired and inspiring. I'm so grateful, truly, that you were able to join us today, and look forward to more. Now, would it be possible if we have you know, an RNPA who's run into a problem or has questions to contact you. Would you be willing to
Yes.
share your contact information?
Absolutely. I can send it all to you, or I can, however you want to do it. I can just give it people, I can give you my number
Let's
right
do
now.
it. Let's do it so it's right on the recording.
Okay, so I'll give you my phone number. If you call, it's 315-605-8005. I'm the only one that answers that line. It's totally private. So don't worry about HIPAA. You can talk to me about anything.
Would you
No one
say it
else-
again, please? Say it again.
315-605-8005.
Okay.
And the only time I won't answer is if I'm in a room with somebody
Or sleeping.
ready. Yes. Other than that, I will answer the call, or I'll follow up with any voicemail. I also have my email, which is jvondell@promisepc.com.
And Misty, if you would do that with the email.
She's way ahead of you. She is
Oh.
way on top.
She's always way ahead of me. Honest to God,
Yes.
she's valuable.
So I am, this did not go, actually, this was fantastic. It wasn't exactly what I expected. But you know, as being a nurse, we know nothing is ever as we expect it to be, that we're flexible. And I'm glad I didn't sit here and just read a PowerPoint to you, because I think that that's not very
Sorry.
productive.
No.
But I'm glad that you have that resource. I did put a lot of information in there about some of the things you might want to share if you get an opportunity to get into a building. So that's in there. There's a little bit of
Yeah,
little bit of
everyone has
information.
that. Everyone.
Yes, it's a little bit of
Everyone has it.
information about myself, about why I chose to do what I'm doing. And, but everything in there, there's two main things. It's all about building relationships, and it's all about the client and quality of care, and that we can get our services, which are also fantastic, to them in the most efficient way, but also in a way that we meet all their needs and that we honor them, because that's what it's all about. And that's why I do what I do. It's to honor my mother and father-in-law, who I was involved with their care before I was even a nurse, and as I became a nurse. And I'll be grateful to them forever for all that they ever did for me. And that put me on this journey to figure out how I can be part of making other people's experiences hopefully much better than what theirs was. And I'm
Well,
really glad to have met you all, and I hope that this is just the beginning. And if I can help in any way, I would be very glad to be involved.
I'm delighted and very, very grateful. Do we have any last minute questions, comments before we let Jacinta go so she can have dinner?
Just one quick thing that I didn't share is one of the things that I've been doing is meeting with the community liaisons of the facilities.
Did Jacinta go?
No, I'm here.
Oh, okay.
Yeah, just a quick point. I have found that to be tremendously helpful, because that community liaison then introduces me, like I'll meet with them separately, sort of in a networking sense, and then go to the facility. She gives me a tour, introduces me to people before I have that resident moved into the facility. And so I have found that to be tremendously helpful. And, you know, it gives me a chance to educate too, so.
That sounds really wonderful. And I know several of our facilities up here do have community liaisons. Not all of them, some of the smaller ones don't, but it's a wonderful idea. And if we can get that to transition into the smaller facilities that maybe don't have that, that will help a lot, and only let them know what a benefit it will be to incorporate you guys into being part of our team.
Well, I thank you, truly. This has been an amazing, and it's going out all over the place. I know that many will be happy to receive the recording because they couldn't be with us today. Jacinta, I look forward to working together with you more because we are pretty much on the same path.
I like that. I'll walk the road with you.
Yeah. I thank you. Thank you very much for being with us.
Thank you so much.
Thank you.
All right.
Thank you.
Bye-bye.
Bye-bye.
Bye.